Well, welcome to another episode of Revision Exercises in Clinical Immunobiology, and today we're talking about the innate immune system. Not many immunodeficiencies arise from the innate immune system, but this is one that it's worth just having heard about. It's rare. Most practitioners won't come across this disease in their lifetime, but questions get asked and you do need to be able to recognise the occasional patient that may come across your practice. Now, today's episode was inspired by this recent article. If you don't find this exciting, then you're probably not interested in internal medicine and the genetic future thereof, because it's really a fantastic demonstration of what's ahead. So even if you don't want to know about CGD, be aware that new techniques are coming across and being discovered and being used, put into practice to correct genetic disorders, of which this is one. Well, you can open your books now to the chapter on innate cells. You know which book I'm talking about. Flick open to this bit. We're now talking about phagocytic disorders, and there's one major one, namely CGD. So what's CGD? Well, it's pretty rare, about 1 in a million, like this is normal for immunologists to deal with. They mostly arise in pediatrics, but the occasional patient will slip through into adulthood, so it's worth having one eye on this, on the ball here. And the molecular defect is in NADPH oxidase. Now, in the book we talk about how phagocytes kill, and one of the ways they kill is to generate highly reactive oxygen species which breaks down what is in the phagosome, or one of the things that breaks down the components of a phagosome. And if this NADPH oxidase does not function properly because of a genetic mutation, then you don't generate those oxygen radicals and your intracellular killing is impaired. And that puts you at risk of various infections, which you'll get to. Now, NADPH oxidase has 5 chains listed here, 4 of which can be or have known deficiency disorders, and the P47 is the subject of that article, which I will come back to shortly. So how do they present? Basically, the innate immune system defects point to high-grade, in this case catalase-positive bacteria, fungal infections, non-tuberculous mycobacterial infections, mostly affecting the skin and the lung, the gums, the perianal region. Those are the two dirtiest ends of the gastrointestinal tract, if you like, but sometimes other tissues, lymph nodes, liver. The first patient I ever saw as a junior basic trainee had Crohn's syndrome, as was the provisional working diagnosis until CGD was discovered. So even gastroenterologists need to know about this. Osteomyelitis also can occur. So once you suspect the patient has this diagnosis, what do? You need a test of neutrophil oxidative metabolism, and the traditional test was an MBT slide test. Some labs still do this. Most have switched across to a flow cytometry-based assay, dihydrorhodamine reduction, or DHR test, where you measure by fluorescence intensity the generation of oxygen metabolites, and if they fail to be induced, this points towards this diagnosis. And of course, most things after those initial screens can then go on to do more specific genetic testing. So once you've found it, what are the cornerstones of treatment? Perhaps this is getting into too much detail, so just note it for the moment, and it's not terribly difficult. So antimicrobial prophylaxis, both bacterial and fungal. There's evidence that interferon gamma injections can boost macrophages or otherwise boost up the immune responses and help with some of these infections. That's controversial. Not everybody believes it. Obviously, you treat acute infections aggressively with antibiotics, early consideration of a fungal infection, drainage, etc. And you treat the inflammatory complications which can occur in the normal way with steroids and second-line immunosuppressives. But the only way of curing the disorder, of course, is by reversing the genetic defect, and hematopoietic stem cell transplantation, usually allogeneic, gives you that opportunity of cure. Of course, it's not without its risks, and you know all about those, and I'm not going to go into those. And deciding, because these patients don't sort of die early in childhood like SCID, deciding when or if to do HSCT is one of the difficulties of managing these patients. But emerging therapies are coming on, and this paper outlines exactly one of them. And it involves prime editing. So read through this paper if you can. Really interesting stuff. Basically, they look at two patients with CGD with the P47 autosomal recessive defect, and they apply this protocol where they take autologous stem cells and correct the deletion of two nucleotides in exon 2, and then reinfuse those cells into the patient with some conditioning with busulfan, and they find successfully, I guess it wouldn't be published if it hadn't been successful, that the neutrophils and platelets graft just fine, and they importantly could detect NADPH oxidase activity at least within the first 6 months or so. Whether this will translate into clinical benefit, we'll just have to watch this spot, but it was exciting enough to get it published at this early stage just on the basis of those physiological improvements. This was well tolerated except for the busulfan, and of course that would be expected. So what is prime editing? Look, I'm not a geneticist. I'm not going to go through it in detail. I don't think I could. You can flick over to Wikipedia or ask your favourite chatbot to explain it in more detail. But basically, to cut a long story short, a search and replace genome editing technology where there are targeted DNA changes which are then corrected, and these changes that can be corrected include insertions, deletions, and base-to-base conversions. It has the advantage of not having to introduce double-stranded breaks, so better tolerated for the cell. Basically, you need a fusion protein, which involves Cas9, nickase, and reverse transcriptase, a guide PEG RNA, which provides the corrected sequence. And then once the DNA has been repaired, the new sequence is preferentially inserted, corrects a defect, and you can then reinfuse the corrected cells into the patient and hope they'll engraft and then obviously take off. So, important things, just a quick revision of CGD. I want you to be aware that this is a defect of the innate immune system dealing with oxidative metabolism. Now, as rare as these things are, a lot of immune deficiencies tell us a great deal about how the immune system works, and this is no exception. And we have appreciated the importance of this oxidative metabolism and how macrophages kill after phagocytosis. So it gives you an example of impaired intracellular killing. Remember that 4 major subunits may be deficient. One is on the X chromosome, all the others are autosomal recessive. They present mostly in pediatrics, but some can turn up in adulthood with recurrent infections with bacteria, fungi, and non-tuberculous mycobacteria. And the reason to remember that is they are typical of innate immune defects. So we divide immunodeficiencies into 4: B cells, T cells, innate defects, and complement defects. And you should know exactly the sort of spectrum of infections to expect with each of those 4 pillars of immunity. Usual management of CGD is fairly obvious to the general physician. Prophylaxis, acute treatment, consider interferon gamma to boost macrophages is what they do, and consider these more definitive therapies which are emerging. All right, that's all I want to say. This is a list of all my learning resources. So I draw your attention to the primer, which is available in all the links which I've put at this site, including Amazon US for the print version and ebooks via Kindle and Apple Books. You should follow me on Instagram. I put lots of questions, which hopefully will be interesting to you. Over on the Patreon site, I put the handout of this lecture. So if you want to join as a subscriber, you'll be able to get access to PDFs of all these lectures. You know about the YouTube, and remember, check out my video series where I go through all 25 chapters of the book, presenting that in a lecture format. I will let you admire the view of the Hunter Valley. I will catch you next time.